I'm happy to introduce everybody to Dr. Zara Cooper. I was going through her CV and her bio, and the thing that I was thinking about was that one of the things that I think unites all of us as geriatricians and palliative care doctors is that we really want to do the right thing for our patients. And even when things get complex for an older person, we still really press in to figure out what doing the right thing means for them. And I think that I'd like to introduce Dr. Zara Cooper as a geriatrician and palliative care physician who's asked those questions as an accomplished trauma surgeon in her field. As a researcher and as an advocate, I've seen that she's written extensively about the implications of surgery in older persons, and that she's thought really hard about what surgery means for the long-term health and well-being for her patients. I was trying to think almost like of what a book title would be if she wrote one. I was like, it's almost like When Steel Meets Flesh, just this combination of thinking about, you know, the seriousness of surgery, but also the significant implications in human side of things. She's well credentialed. She's an associate professor of surgery at the Harvard Medical School. She's a trauma surgeon. She founded and directs the Center for Geriatric Surgery at Brigham and Women's. She's also a director at their Center for Surgery and Public Health, and she chairs the Executive Advisory Council on DEI at Brigham Health. So she'll be talking today about how we can collaborate better with surgeons and systematically improve the outcomes for older persons. And without further ado, Dr. Zara Cooper.
Well, thank you so much, Kenny. I don't know, can you all hear me? I hope. All right, thank you so much. And I love that book title. I think that's perfect. That's absolutely perfect. All right, I'm going to try to share my screen, and you know, my apologies because I'm still a novice at this, it feels like. Let's see, there we go. All right, just 1 second. I want to thank everybody because I've had a really fantastic visit with everybody. And again, I'm really sorry that we can't do it in person. Give me just 1 second still, I apologize. Okay. This is very good. So can you see my screen?
Yep, you're good.
Okay, great. So today the title of my talk is Standing on the Shoulders of Giants, GeriPal and Surgery. And obviously that's a nod to Alex and Eric, and to thank them for their leadership and also for their inspiration in, you know, helping me create a path for geriatrics and palliative care and surgery. Today, my intent is really to share with you, you know, some lessons that I've learned from my journey and my research, and hopefully to enlist some of you in my advocacy and my crusade to really improve surgical care for older and seriously ill adults, because we don't do all the things that we need to do. I think surgeons have so much to learn from you and from your approach to how you care for your patients and their families in both you know, geriatrics and palliative care. And I really hope that you will partner with us. So I want to introduce you, sorry about that. I want to introduce you to Earl. Earl is a 70-year-old man who is recently widowed. He's living with a daughter who is a single mom of primary school age kids. Earl has coronary artery disease. He has congestive heart failure, diabetes, hypertension, and he's had increasing episodes of limb pain and rest pain with walking. And so his functional status has declined over the past month or so. He's largely become homebound because he's unable to ambulate comfortably. He's become increasingly isolated and depressed. He goes and he sees a vascular surgeon who talks to him about lower extremity revascularization. He's had a stent in the past. This has been tried before. He's on antiplatelet agents. He gets admitted to the hospital after it's agreed that he should have lower extremity revascularization. His hospital course is complicated by postoperative bleeding. He's taken back to the operating room. He's admitted to the intensive care unit. He has ICU-related delirium. His hospital course is then complicated by an aspiration event. And then on hospital day 14, he's discharged to a skilled nursing facility. And when I think about this patient, I want to tell you that this is a very typical surgical patient. This is a typical vascular surgical patient. And when I think about all of the opportunities to integrate palliative and geriatric principles of care in his care, it's really quite alarming. And so, I want you to think about Earl, not necessarily because of all the complications that he had, although obviously those were serious, but I also want you to think about him because he's not unusual. This is something that we see, and he was discharged. This is not necessarily about compassionate end-of-life care, although as we'll discover through the talk, and you all know this better than I do, his prognosis and his longevity are not great. And so there's definitely a role for palliative care and geriatrics in the routine care for somebody like Earl. I also want to say that, surgery is expensive and it's a huge part of healthcare utilization. Cardiac orthopedic surgeons and neurosurgeons generate the highest average annual revenue for hospitals. And 29% of all aggregate healthcare expenditures are surgical, and almost half of those are elective surgery. And in fact, it's projected that by 2025, which is just a few years away, that surgery will account for nearly 7.5% of total US GDP. And so if you're interested in impacting how healthcare dollars are spent, how healthcare utilization occurs, then you're interested in understanding the implications and the importance of surgery and surgical patients for older adults. The other thing that I would say is that an increasing number of surgical patients also meet criteria for serious illness. If we think about the course of chronic disease and we think about the course of serious illness, surgery is often the end of the common final pathway for much of that. So for example, chronic kidney disease, transplant, heart disease, transplant, VAD, coronary disease, CABG, vascular disease, bypass, revascularization. And so the list kind of goes on and on. But as we think about, the sequelae and the aftermath of chronic illness and of disability, surgery often has an important role to play. The other thing to think about is cancer. In thinking about cancer patients, nearly 80% of cancer patients will have surgery over the course of their illness, whether it's for cure or for palliation. And so that's a huge segment of the seriously ill patient population who will come under the care of a surgeon at one time or another. Also important to recognize that the numbers of patients, and particularly older patients with cancer, continue to increase. And while our guidelines and our societal recommendations, or I should say the professional society recommendations, recommend that geriatrics and palliative care are available to older and seriously ill patients no matter where they receive care, surgery remains a gap. I also want to impress upon you the importance of trauma. As mentioned, I'm a trauma surgeon. I've had the opportunity to talk to a number of you about my trajectory, and I went into trauma surgery because I am an adrenaline junkie. I love the rush of the trauma bay. I love rescuing, typically otherwise healthy people from, life-threatening injuries and restoring them back to health. But increasingly, I find, as many trauma surgeons do, that an increasing number of my patients are in fact geriatric. And my introduction to geriatrics actually happened when I was an acting fellow at Dana-Farber on the palliative care service here. And so just a little bit about my background, as mentioned, I'm a trauma and acute care surgeon. I developed an interest in ethics and palliative care when I was a critical care fellow, which I did in the middle of my residency, actually. I then did a trauma fellowship at Harborview Medical Center in Seattle, and those trauma surgeons actually had a very good relationship with the palliative care team, and palliative care was introduced into the care of trauma patients with some regularity. And so I was exposed at that point, and it wasn't until I was a critical care attending back here at the Brigham that I really started to understand the gaps in my own skill set, and that I needed to understand palliative care better to provide more holistic care for my critically ill patients and their families. And so with the encouragement of leaders in our institution and leaders in the field like Susan Block, Janet Abram, James Lima Thomas, I was encouraged to pursue palliative care training, and then ultimately decided to become board certified in hospice and palliative medicine. At the time, I could grandfather in. This was 2012, and so I could still grandfather in without doing a full year of palliative care fellowship. I organized my clinical schedule so that I could accommodate approximately 8 months of clinical time at Dana-Farber. And while I was an acting fellow in the IPCU, in the inpatient palliative care unit, it was there that I looked around and I said, you know, these patients have a lot of the same nutritional issues, wasting, cachexia, functional disability, delirium, cognitive impairment that I see on my trauma service. Yet these patients are on average about 20 years younger than the trauma patients that I'm taking care of. And that's because over the last 2 decades, we have seen a nearly exponential increase in the amount of geriatric trauma. And in fact, in level 1 trauma centers like mine, more than 50% of our patients are geriatric. And what we know about geriatric trauma patients is that they fare far worse than younger counterparts. Geriatric patients with traumatic brain injury and with rib fractures are twice as likely to die in the hospital. Approximately 70 to 78% of those patients have existing frailty and functional impairment before they have their trauma. And many of them are relegated to skilled nursing facilities and assisted living after their injury. This is a major life-changing event that often can change their health trajectory entirely. And so this is also a major opportunity for geriatricians and palliative care clinicians to really partner with us to provide the best care for a growing number of patients. I also want to talk to you about emergency surgery, which is the other surgical hat that I wear. You know, emergency surgery like acute cholecystitis, or cholecystectomy, I should say, acute appendicitis, perforated colons, perforated ulcers. You know, these are conditions that are really due to a lack of pre-existing care or underlying serious illness. And so when I take care of these patients, I joke that I'm a surgical oncologist in the middle of the night because, you know, at the Brigham, we're affiliated with Dana-Farber. And so, you know, many times I find myself taking care of patients who have advanced cancer and obstructions, who have advanced cancer and perhaps calculus or acalculous cholecystitis, perforated gallbladders because they're on high dose steroids, perforated colons or gastric ulcers because they're on high dose steroids. And so, you know, I encounter patients when they're in very late stages of very advanced disease, and now they come in with an acute illness. And we know that 40% of patients who undergo emergency surgery are in fact older adults. And the data that I'll show you shortly really underscores how ill they are at baseline. And so again, I just hope that this impresses upon you that there's a real need for attention to be paid for geriatrics and palliative care and surgery. So, you know, I'll tell you about, actually, let me go back to this. I'll tell you about a patient that I took care of who really informed kind of the first couple of years of my research. And he was about 71 years old. He had advanced lung cancer. He was on 3rd-line chemotherapy. He presented to me in the emergency department with a rigid abdomen. He had peritonitis. He had hypotension. He was confused. And what I learned from his wife and his daughter who were at his bedside is that, you know, he had been having, you know, increasing amounts of pain. He had bony metastases. He had been started on very high dose steroids, and he was actually having some hemoptysis that he was not telling his oncologist about because he was worried that his oncologist would take him off of his chemotherapy. So really holding on to his chemotherapy as his lifeline. And that over the you know, preceding days, he had become increasingly bedbound and confused. And so he presented to me with a perforated viscus. He had free air under his diaphragm on his chest x-ray. And it was clear that he had a surgical illness. You know, this is a patient that I took care of very early in my career. I didn't have the prognostic understanding of where he was in his illness trajectory. I didn't have skills like I didn't have knowledge of the palliative performance score. I didn't have an understanding of serious illness communication and how to talk to, you know, this man and his family about what we could expect for surgery. And so the way that I understood it was, well, we can operate or we can do nothing. And I didn't really understand what doing nothing signified to him and his family in terms of abandonment, and really just leaving somebody to die. And so I operated on him with the best of intentions. He actually survived the operation, and he was in our intensive care unit for approximately 3 weeks before he had been on dialysis and, prolonged ventilatory support. And, we finally had conversations with the patient and his family about withdrawing life-sustaining treatment. That case taught me so much about the importance of understanding all of these elements of his overall health status, the importance of understanding the role that this patient had in the life of his family, and also the importance of interdisciplinary and multidisciplinary care. As a surgeon, I had been taught to go it alone. But had I really leaned on his, on the expertise of the clinical team that was taking care of him, I might have had a much better understanding of what surgery could and couldn't achieve. And how unlikely it was, given his performance status, that he was ever going to make it home. And that, that should have been a really important part of the decision making. I was certainly equipped to talk about complications, but I wasn't necessarily equipped to talk about the implications of surgery. And again, this is stuff that I have learned from palliative care and geriatrics and helping me think about this. But as I said, it did inform my research. And one of the questions that I had was, I don't actually know what his mortality risk is. I don't know what the trajectory is. And one of the challenges that we have as surgeons in trying to prognosticate and to counsel patients and families is that we don't have a lot of data on what happens to patients beyond 30 days after surgery. And that was actually the title of my K award, was Understanding Surgery Beyond 30 days. As I said, this is really a talk about how I have stood on the shoulder of giants. And so I will show you about how I've collaborated with geriatric and palliative care researchers and learned from them to really try to inform surgical care. So this is work that I did with Amy Kelly at Mount Sinai, or which I think is sometimes called UCSF East, but this is work that I did with Amy Kelly. And we used the health and retirement study that I know is so well known to many of you, to identify a cohort of older patients who had experienced an emergent laparotomy between the years of 2000 and 2014, and to link that data to Medicare claims to look at their mortality. And what we found was that for patients we had a cohort of about 411 patients, and for patients who were between the ages of 65 to 74, the 30-day mortality was about 13%. That wasn't a huge surprise. But the 1-year mortality was about 23%, which was certainly higher than I had expected. When we looked at, the next group of patients who were 75 to 84, 1-year mortality was as high as 35%. And then we looked at patients who were 85 plus, which again, I don't need to tell this group is the largest growing segment of the population. In fact, nearly 50% of them had died within 6 months of an emergent laparotomy. That's very important prognostic information to help counsel patients and families, that if you look at this particular group, almost a third of them will be dead in 30 days. Almost half of them will be dead in 6 months. And so thinking about what are the chances that they'll have, any kind of recovery? What are the chances that they'll ever be able to live independently if they came independently? Those sorts of things are not remote. Those are pressing issues, but having an understanding of what these survival curves look like can really help inform these conversations. I also did work with Amy using the health and retirement study to look at the high burden of palliative care needs of this same cohort of patients. And this was work that was based on a study that Christine Ritchie and Alex Smith did, looking at the burden of palliative care needs of patients who had hip fracture. And I thought, I have a similarly ill group of surgical patients, and I would love to look at this. So we used, data again from the health and retirement study, and the cohort if we look at patients who had a high illness burden, which is, to signify palliative care needs, the cohort of 411, almost 2/3 of them had high illness burden at baseline. And what were the criteria for illness burden? Looking at age, nearly 65% of these were female, white, but the criteria for illness burden included ADL independence, helpers, whether or not they had dementia, comorbidity as marked by the Charlson score, whether or not they had high healthcare use in the year prior. And this is my favorite part of the entire talk, the number that had a Lee index of greater than 14. And the reason why it is my favorite part of this entire talk is that this is the only audience where I don't have to explain what this is. So I want to thank Dr. Lee for his important work and the opportunity to present this to him. And we looked at survival and stratified it by illness burden. Here you can see with the low illness burden in the blue, the full sample in the green, and then the high illness burden in the red. First of all, these survival curves look very similar to the ones that I showed you. So if we stratify by age or if we stratify by illness burden, we see that the patients who are younger or have low illness burden, again, almost a quarter of them will die within a year of surgery. If we look at patients who have high illness burden, again, 2/3 of this cohort, about half of them will die within a year of surgery. So this is clearly a group of patients who come to us with pre-existing palliative care needs, and that's before we operate. So again, in my mind, this signifies the importance of palliative care for these patients. We then looked at other data, looking at 100% Medicare claims, and I was interested to understand what did end-of-life care look like for older EGS patients who die within a year, and whether or not frailty was associated with end-of-life outcomes. And so again, kind of standing on the shoulder of giants and collaborating with geriatricians and palliative care physicians, we worked closely with Dae Kim and used his Medicare-based frailty index to identify frailty in this cohort of patients who had EGS. And I apologize for this typo, but it's patients who had emergency general surgery. And in this cohort of almost 140,000 patients, what we found was that 6.3% of them were moderately or to severely frail. But also, if you look at this, about 1/3 of them were not frail, but the remainder had some degree of frailty. They were either pre-frail, mildly frail, or had moderate to severe frailty. And if we look at end-of-life care, specifically looking at ICU admission, ED visits, rehospitalization within the year before death, what we find was that within 30 days, the last 30 days of life, that the highest odds of healthcare utilization were in fact among the moderate to severely frail group of patients. And so again, identifying patients who are frail up front, recognizing that they're at the highest risk of adverse outcomes, having conversations about end-of-life care, may I dare say advanced care planning or serious illness conversations to this audience, could be really helpful for this group of patients and perhaps avoid high healthcare utilization and unwanted, unnecessary, burdensome treatments. Or it could clarify the treatments that are wanted and that could improve quality of life and be life prolonging. One of the other things that we did was we asked, and this was actually, again, standing on the shoulders of giants. This is work that was informed by some of Alex Smith's earlier work with emergency department, patients in the emergency department and their physicians in understanding their thoughts about palliative care. And so in work that I did with a mentee of mine, Christy Cawley, who's now a colorectal surgeon at Mass General and a mentee of Christine Ritchie's, and mine, we did some semi-structured interviews with acute care surgeons, a national purposive sample of acute care surgeons at various stages of their career. And we presented them the same vignette of the patient I told you about, the 71-year-old who had lung cancer and a perforated viscus from high steroid use related to his chemotherapy. And we asked them, what do you think would be the probability that he would survive 72 hours without an operation. And here you can see on the x-axis, the participant number. We had about 24 participants before we reached saturation. On the y-axis, it's the percent survival estimate. And what I want to impress upon you is that most of the respondents thought that he had a 50% or greater probability of death, but there's pretty significant variability here. We then asked the same group, well, what do you think his length of survival would be if an operation was performed? And again, here you can see that there's significant variability. However, the vast majority did think that he had less than 6 months to survive. So what does this mean? This means that if you ask a purposive national group of acute care surgeons about this patient, most of them think that he would be eligible for hospice. Again, identifying an opportunity for palliative care to be considered as part of his treatment, whether he has surgery or not. The other thing that I want to impress upon you is that, again, these estimates are all over the place. So what this means is that the information that you get as a patient or a family member really depends who's on call, right? And so with that level of uncertainty, again, learning lessons from people in this audience about managing uncertainty and understanding the importance of uncertainty in clinical decision-making, and helping patients and families manage that uncertainty, we decided to create a framework for serious illness conversations in emergency surgery. And so this is work that I did with Susan Block as part of her group at Ariadne with Atul Gawande, and we convened a multidisciplinary advisory panel of 23 experts to develop a prototype communication framework for best practices for surgeons who are confronting patients in these situations. And what did we recommend? I mean, none of this is rocket science, I'm sorry. What did we recommend? We recommended that, and it should show up here, and I apologize that it's not, but we recommended that physicians sit down and introduce themselves. We know that 50% of the time, clinicians don't even introduce themselves to patients and families. We recommended that they talk to other clinicians, that they participate in interdisciplinary care, that they understand what the patient's underlying health issues are and what their trajectory is before they go in and meet the patient as best they can. That they try to develop a shared understanding with patients and their family members. And so, in reflecting back on the patient that I told you about, how important it would have been for me to reflect back to the family that he had been declining rapidly, that he'd been having a great deal of pain, that even with surgery, I wouldn't have been able to make him any better than he was really right before he had the perforation. And so really thinking about that information as it relates to his quality of life versus longevity. And then talking about how the acute illness can really influence and impact the care trajectory, particularly important for cancer patients who, as I described in this case, really were holding on to chemotherapy as his lifeline. Chemotherapy was not going to be possible anymore with or without surgery. And so that was obviously going to significantly curtail his survival. And then talking about his goals and values and what was most important to him and what are the things that he wanted to maintain. And perhaps rather than operating on him and taking him to the intensive care unit, convening the family so that they could be with him at his bedside and he could die peacefully in pain and without pain and treated in a palliative manner. Really exploring all of the different treatment options, not just saying surgery or doing nothing, and recognizing that the principle of non-abandonment is so important, particularly to patients who are so intertwined with the healthcare system, that, to say do nothing is really, really means abandonment to these patients and their families, and that it's not do nothing. It's still intensive care, no matter what the goal may be. And then, of course, again, convening with the multidisciplinary team and documenting all of these things. documenting the conversation, documenting the wishes, and making sure that it's passed along so they don't have to have the same conversation over and over again. None of this is rocket science, but it was truly somewhat revolutionary in surgical circles. And I will say that this paper has been highlighted as in a recent publication as one of the 50 journal articles that acute care surgeons need to know, because it's really a very practical guide. But this is, serious illness communication that geriatricians and palliative care clinicians learn in their daily practice. This is a patient, again, another vignette, a patient of mine. This is a patient, Ken, and he is an 83-year-old man who has pancreatic cancer and presents to me with a small bowel obstruction. This is a very common diagnosis, and in fact, it's a common diagnosis for surgeons, even though many of these patients are treated medically and they're treated on the oncology service. Research that we've done has shown that about 98% of the time that these patients are admitted to the hospital, a surgeon is involved. We know that their mortality is very high in the 3 months after surgery. And we know that surgeons are involved frequently, but palliative care may not be. And so, in thinking about this patient and then thinking about other patients that we've cared for, we've really highlighted that the type of treatment that they receive can be strongly influenced by, what happens at that first hospitalization. Again, going back to my K award and my, real desire to understand what happens to these patients beyond 30 days, we took a cohort of patients, not all with small bowel obstruction, but who had emergency surgery. And then we followed them 3 months later, and we asked them, how they made the decisions that they did, in part because, as I've had, conversations with many people today, so much of what draws many of us to this field is this kind of existential distress that we have in our lack of communication, and really, how much do patients understand at the time that they're making a decision for surgery, and how much information can we give them, and how much do they process? And so we did semi-structured interviews with a cohort of about 30 patients and asked them about their decision making. And there were a couple of domains that became clear to us. So, there were emotions that were associated with in the moment decision making, like regret, fear. I wish I had gone to the hospital sooner, when I would have started having cramps, because then I would have been able to do something about it. I caused this. I was scared to go under the knife, but I don't understand. I don't remember the surgeon's name, but I knew that I was in the best place possible. The desired outcome was that they just wanted it fixed, and they fixed it. The perception of patient choice, and I think this is a really important point and something that my colleague and friend Gretchen Storsey has talked about in her research as well. The patients don't actually feel like in the moment they have a choice. I don't think I decided at all. I think they decided. I had a perforated bowel, so I was leaking into my, the rest of my body. So that's never a good thing. Well, there was no real way that I could not have surgery. It was something that I didn't really get a yes or no on, because if I didn't have surgery, I would have died. And then, this value of prolonging life. Everybody loves life. It's a chance that the end wasn't at all. So if it's a chance that wasn't the end all and be all of my life, then I would like to live. Barriers to participation. We had to move fast. So I guess I don't think there's anything different that they could have done. Again, there's no choice. And I think one of the things that's so important in thinking about how palliative care can influence, in the moment decision-making here, is thinking about symptom burden. I had no choice. I was in constant pain, and really understanding from a surgical perspective that if we want to engage in high quality decision making, that in fact we have to tend to patient and family symptoms, anxiety, distress, pain, before we can really engage in those conversations. Sometimes patients are too sick. One question that we ask is, sometimes patients are too sick to let their care team know their treatment preferences. What did you have in place to let the team know the type of care that you would have wanted? And here, we talk specifically about advanced care planning in the moment. And what we found was that, there was reluctance to think about it, that there was no previous, that there weren't necessarily previous discussions, or, I have a living will, everything is spelled out, signed legally from a lawyer, so it's all clear. My daughter has all the rights to say yes or no. It wasn't planned and it wasn't welcomed. And, in thinking about future advanced care planning, I don't want to think about it. Why is this important? I think it's important because from a surgical perspective, what it means is that in the moment decision-making really needs to be guided by the surgeon. I think serious illness conversations are really important in helping prepare for these moments, but these moments are often a moment of existential crisis, of high symptom burden. And so surgeons also need to be engaged in these conversations. We can't just rely on our colleagues who have these conversations up front, or on patients and families to be able to think clearly or recall necessarily what's happened in the past. And so I'll give you an example of this from my own practice, where I took care of a patient, a very ill patient who was in his mid-80s, and he actually had a car crash on a highway on the way back from his cardiologist. The patient himself was a former judge. And I always joke in Boston that everybody's a doctor, a lawyer, or married or a nurse, or married to a doctor, lawyer, or nurse. He had 8 children. They were all doctors, lawyers, nurses. And so they all had a great deal of knowledge. And he actually had one child who was a surgeon, not a trauma surgeon, but was a surgeon. And they all lived all over the country. It was a very, very tight-knit family. They all flew back, and we had family meetings every day. This family wanted complete updates. They wanted total information. They wanted, they really wanted to participate fully in all the medical decision-making. But what I was really struck by was I had asked them a number of times, does he have advanced directives? Has he ever told you his wishes? And they were so distressed by the events that they were happening that it wasn't until about day 4 or 5 that somebody remembered that in fact he had volunteered at a hospice, and that in fact in his bank, in his secure deposit box, there was in fact documentation of the kind of treatment that he would have wanted had something like this happened. And so, it was important that for me not to necessarily rely on them to have that information, but also he hadn't discussed his wishes with his children. They didn't know. It was all just in a document. And so having those conversations up front would have been very important. One of the other things that we've considered is symptom burden. And so this was actually work that I did with a mentee of mine, Elizabeth Lilly, who graduated from was a research fellow with me for 3 years, and then graduated from our surgical residency, and then did a palliative care fellowship at Dana-Farber, and is now a surgical oncology fellow at MD Anderson. And I tell you all that because she is a rock star, and I want you to look out for her. I have other mentees that are actually coming to UCSF, so I want you to look out for them too. But one of the things that we were curious about was, what is the role of surgeons in tending to symptoms for older patients who are undergoing oncologic surgery? With all of the new treatments and neoadjuvant chemotherapy, there are many patients who will come to surgical attention who have already had chemotherapy. And so we did a chart review of 20 different patients who had been seen by surgical oncologists over a 1-year period at Dana-Farber. And we just went through their charts looking for symptoms that were documented during their preoperative visit. And what we found was that there was a long list of symptoms, including all of these that are on this slide here. And again, these are patients who are coming with this long list of symptoms, most of which will not be improved by surgery. They won't be addressed by surgery. So it's important to note these, to record these, and for us as their care providers and clinicians to hold ourselves responsible for tending to these, whether they're under surgical care or not. And so I'm really excited to do work going forward with Liz and others to see what impact symptom burden has on surgical outcomes. And I suspect that we're going to find that there is a relationship, and again, an opportunity for palliative care to improve not just the patient experience, but outcomes in surgery. This was work that was inspired by Catherine Ornstein when she gave a talk at MPCRC. I'm sure that Catherine and her work is known to many of you, but she is an epidemiologist who specifically looks at caregiving and really inspired me to understand the caregiving needs of older adults who undergo trauma. And so I was fortunate enough to receive an award from MPCRC and to work with Catherine and also to work with Amy Kelly and others to use NHATS data, but then also to do some primary data collection to understand caregiving needs after trauma. And not surprisingly, when we look at a cohort of older adults, you know, and we compare the needs for assistance before trauma and after trauma, you know, we can see that there's a pretty significant increase. So, you know, almost 20% increase in patients who need any assistance, you know, pre-trauma, you know, post-trauma, more patients need assistance with self-care, impaired mobility, they need help with household items. But we also notice that there's an increase in adverse consequences due to an unmet need. So the question in NHATS is, do you need assistance and did you have needs that were unmet? And again, here we go, pre-trauma is in the black and post-trauma is in the gray. And in post-trauma, there were, you know, nearly twice as many patients who had unmet needs at all, specifically related to self-care and mobility. And so, you know, this is pretty significant when we think that the numbers of older trauma patients are increasing so rapidly, that the amount of post-trauma disability is really quite startling. One thing I'm going to just for the sake of time, I just want to look at this because I think that this is really interesting. When we look at the Zara score at follow-up on the y-axis and the score at baseline on the x-axis, and we look at this red line, which shows the burden over time, what you can see when we look at caregiver, when we look at interviews where we had both data at both time points, what we find is that for 54%, there's actually an increase in burden over time. So although, you know, overall, when we look at the overall cohort, it works out that it's about 31% at each time point. For patients for caregivers where we had both time points, there was an increase over time for the majority. So again, there's more work to be done. Briefly, I want to just share with you some exciting stuff that we've been doing related to quality measurement. And this is work that was informed by Charlotta Limval and Annie Walling, looking at using natural language processing and developing quality standards for palliative care and surgery. This is work that I was really proud to participate in with the American College of Surgeons Trauma Quality Improvement Program, palliative care best practice guidelines. But in thinking about putting out these best practice guidelines, it's also really important for us to understand how are we going to measure the effectiveness of what we're doing? How are we going to figure out whether or not these guidelines are being followed? And so again, I'm working with Charlotta, and this was work that was led by Kat Lee, who I'm really proud to say is coming to be a palliative care fellow at UCSF next year. She's currently a surgical chief resident at UCSD. She's a rock star, so I'm really thrilled for her that she's matched with you, and I'm looking forward to connecting her with many of you before she arrives. But this was work that she led, really looking at palliative care delivery among our trauma patients at Mass General and at Brigham and Women's. And here we went through over 2,000 encounters. Because of the wonders of natural language processing, we were able to examine almost 85,000 notes. And what we found was that palliative care delivery, as measured by documentation of goals of care conversations, code status clarification, palliative care consultation, or assessment for hospice, actually occurred 29% of the time. The vast majority of that was code status clarification. When we compare that to administrative coding, not surprisingly, we find that administrative coding missed a whole bunch of that, and it was only correlated to palliative care delivery as measured by this about 7% of the time. Why is that important? It's important because if we're really going to be able to measure the quality of palliative care delivery, we need to use novel methods like natural language processing to get to the data. But this also prompted us to think about the importance of quality indicators and including quality indicators as a way to really change practice, that I can kind of bang my head against the wall for as long as I want to, but really the best way to integrate palliative care and geriatric care into surgical practice is to bake it into the systems and the ways that we're held accountable. And so again, under the leadership of Kat Lee and in partnership with Annie Walling and others, we looked at the entire trajectory of the perioperative period and looked for opportunities for palliative care. For the sake of time, I will go through this very quickly, but you know, we did a systematic review following a modified RAN UCLA appropriateness method. We did a systematic review. We found that there were about 31 quality indicators that were related, that were specific to surgery, most of them focused on communication and end of life. And so we vetted and adapted those to surgical patients. Perhaps the most exciting part about this, I think, is that in order to come up with quality indicators and quality measures, we needed to identify what's called the denominator. So again, looking at work that Amy and Ken Kaminski and others did, really understanding what is the denominator of serious illness and surgery. And so we applied a consensus-based definition of serious illness and surgery using Medicare claims. And actually we found that in 2016, there were over 1 million Medicare beneficiaries over the age of 66 who met our definition of serious illness and surgery. And why did we need to have a special definition of serious illness and surgery? Because other definitions don't include trauma patients. And we also had to recognize that there are physiologic burdens related to surgery that make chronic illnesses more treacherous. So I think one example would be liver injury. I'm sorry, not liver injury, liver disease. And so often palliative care is considered, you know, further along towards the trajectory when patients have end-stage liver disease. But patients who are either a child's A or B cirrhosis with very low MELD scores, because of the hazards of anesthesia and surgery, can be at high risk. And so, you know, the criteria for serious illness may be more dynamic in surgical patients. This is exciting because this is something that we can do, that we can apply in administrative data that I think will really push the research forward. And I have a grant to kind of look at what happens here. And again, for the sake of time, I'll kind of pass this, but I do want to kind of emphasize that when we look at the patients who had serious illness and surgery, you know, that a significant number, I should say, that, you know, 33% met criteria because they had trauma. Only 58% of those actually had major surgery. And so there are many surgical patients and trauma patients who don't necessarily have surgery, but will come under this care. Just to give you an example of some of the quality indicators that we came up with, or that we adapted based on what was already out there, is this was adapted from the Care and Communication Bundle, which was work that was done by Judy Nelson and Randy Curtis many years ago. You know, that says if a seriously ill patient experiences a postoperative ICU stay for more than 5 days, then there should be a multidisciplinary family meeting. That was based on prior guidelines that said that an ICU length of stay for more than 5 days should have a multidisciplinary family meeting. And so in summary, I just want to say that where the work has taken me is really around quality measurement. And I'm really delighted because we just got a grant from the John I. Hartford Foundation to partner with the American College of Surgeons to introduce some of these quality standards into the American College of Surgeons Geriatric Verification Program. And the intent here is really to raise the floor of geriatric and palliative care all across the country. And so, hopefully my overarching goal of trying to bake this into what we do will come to fruition. And I want to thank you so much for your time. I want to thank you, Louise, for the wonderful invitation and the opportunity to spend time with so many friends. And I really hope that we have a bit of time for questions.
Thank you so very much. That was just a fantastic talk. Thank you so much. And everybody's really enjoyed meeting with you. So I do have a couple questions and we have time for that. So I'm going to lead off with a question from Dr. Alex Smith. And you also have lots of kudos saying what a great talk. He also says, thank you for the terrific work you're doing at UCSF Boston. Nurses often want to consult palliative care, but the surgical attending refuses. Are there any studies on moral distress among surgical nurses, particularly in the ICU?
Yeah, I think that's a great question. And actually, there are studies about, actually, Rebecca Aslickson did some studies probably 10 years ago when she was still at Hopkins, specifically about the barriers to calling palliative care consultation in the ICU, and used qualitative methods to examine that. And there was a lot of discussion about the moral distress for nurses in the surgical ICU. And I would say, what I would say is that my approach, and you didn't ask this, but my approach to surgeons, because when I'm an intensivist, right, I'm on the other side of that. And my approach to my surgical colleagues is often saying, I need backup. And the same is true for patients, because a lot of patients, they hear palliative care and they say, no. But it's, I need backup. I need help managing your symptoms. I need help with some of the decisions that we're going to have to make. I see that you're really distressed, and I think it would be really helpful for us to get you an extra layer of support. I use that language. And I will tell the surgeon that as well. And oftentimes I will ask for the social worker first or the chaplain first, and kind of introduce it that way. So I hope that helps a little bit. But yeah, there is a lot of moral distress for the nurses in the ICU. Absolutely.
Great. I have another question from Steve Panelat asking about the management of patients depends on the team that's called to see the patient in the ER and when the patient has a relationship with a surgeon. Any thoughts on how to change the system to make this process less random? So that
gosh, hi, Steve. That's first. Hi, Steve. That's so nice that you came. I really appreciate it. How to make the system less random? I don't know. I don't know. I'm just in such distress. I feel like our healthcare system is so broken that randomness is why, quite frankly, it's so incumbent upon all of us to have basic skills in this stuff. And yes, it is so helpful when you have that relationship, but it just seems to be happening with less frequency. I'm not entirely sure what to do. At the same time, I think it's really important for surgeons and other clinicians, and really important for surgeons in particular, to rely on other clinicians to help kind of establish those bonds and those relationships in the moment, in a way that surgeons aren't necessarily known for doing.
Fair enough. And maybe this builds on it. This is a question we've been talking about, is what's the best model for surgeons to work together with geriatricians, with palliative care docs? I mean, we talked a little bit about, consults, co-management, but sort of, since you have the perspective of both sides, or what are thoughts on that, or how do you individualize those kind of decisions?
Yeah, so I personally think, at least for most of the surgeons I know, and orthopedists are different, I will say, but many, at least here, we are not in favor of a co-management model, because we still want to have control over our patients, and we're a referral center, so our patients come to see us. But what I do think is that we've had a lot of success in our trauma service in creating clinical pathways and really doing a lot of elbow to elbow work with the nursing staff, with the social work staff, with the PAs, because we rely a lot on PAs, and with the house staff. So for our trauma service, patients are screened for frailty up front. And we use the FRAIL. It's not very fancy, but surgical residents can do it in the heat of battle. And, once somebody is determined to meet criteria for that, then they go on our frailty pathway. And so that includes medication checks. It includes, proactive kind of health proxy clarification and, code status clarification. And it also includes orders to get out of bed for every meal if they're able, just kind of basic geriatric care that has really been codified. The best thing for us is that our nurses completely own this. And so it has really transformed the culture. And so that even when our doctors don't order it, the nurses tell them to. And also that our residents have enough of an understanding of it that they're now taking it to other services. And so kind of with the success of that program, we were able to get funding from the hospital to start the Center for Geriatric Surgery and to try to expand that. But one of the things that we're challenged by is we don't, as I was telling your fellows and I was telling you, apparently all the geriatricians are there. And so we don't have enough geriatricians to see everybody. And so we're really trying to figure out, at what level do we, how do we provide the coaching and the support around kind of primary geriatrics and primary palliative care that doesn't necessarily need physician input. Yeah. So any advice that you all have for me is great, but I did find that kind of baking it into the culture is really the best way to do it.
Yeah. And that's very inspiring. So I think that is a great way to sort of end our hour together. So again, just thank you so much. It was really terrific and a really terrific day. So thank you so much.
No, thank you. Great to see everybody. Thanks so much.
Take care.
All right. Bye. Bye.